All right, well, good afternoon, everyone, for our multimodality imaging conference. My name is Mohammed Chamsi-Pasha, and the task today is talking about imaging artifacts in cardiac CT and cardiac MRI. And it's not a matter of what artifact you're going to see, it's a matter of when you're going to see it, because practically speaking, you are going to come across a lot of those during your clinical rotations. So to start up with here, Malik, is this structure moving or is it an artifact?
Looks like it's moving.
All right, well, my friend, this is a delusion because none of these circles are actually moving, and this is what we're gonna try to kind of slice and dice with regards to artifacts. So starting with CT imaging artifact, and really the number one artifact we see on CT is motion or blurring artifact. And this can occur because of the heart motion, so cardiac motion, or the coronaries if basically the patient's heart rate is fast. So anyone who has an irregular rate, like fibrillation, flutter, anyone who has a fast heart rate, like even like kind of in the 70s or 80s, or arrhythmias, all of which are gonna cause artifacts, and I'm gonna show you an examples of that. The second thing is respiratory, because we acquire those imaging during breath hold, and if the patient do not hold their breath, they are going to be prone to an artifact. And remember that we try to acquire our cardiac or coronary imaging during diastasis, the period in the cardiac cycle where there's the least motion, because of our limited temporal resolution in the magnitude of 60 to 70 milliseconds. Usually we give beta blockers to slower heart rate, and we all do those examinations in CT with breath hold. So if you notice, basically the most common mode of acquisition on CT is this prospective ECG gating. So the patient's laying on the table, you can see that the camera takes a shot of the image, and then basically the table moves. So you can see this quote-unquote step and shoot phenomenon where the machine is actually acquiring set of images here in diastole, then the table moves, as you can see here, it acquires another set of image, the table moves, and then you acquire another set of image until you have the full cardiac field of view in the plane. This diagram elicits the velocities of the coronary arteries on the y-axis versus the phases of the cardiac cycle in the x-axis. I hope you all agree that the right coronary artery, it really has the fastest velocity in terms of coronary motion compared to the LAD and the circumflex. The circumflex here shown in green, and the LAD is actually kind of in blue. So remember that we have two periods in the cardiac cycle where these coronaries are moving less. So technically we have the 70 to 80% phase, which is mid to late diastole, right before the atrial kick, because once the atria kicks, notice how the RCA and all the coronaries have a very fast rise in their velocities. And the other one is during the isovolemic relaxation time after the aortic valve closes and before the mitral valve opens. So these are the two periods, the 70 to 80% and the 30 to 40% where we want to acquire our images depending on the patient's heart rate. And really the ultimate result is I want to have a motionless coronary artery, as we can see here on a sagittal reconstruction image. So how does motion artifact in the right coronary artery look like? Take a look at this axial stack. Notice how you have this winging and blurriness of the edges of the right coronary artery. I hope you all appreciated there is actually a winging appearance here or blackness. There's also some blackness around the other adjacent area. And again, the reason why we see this is because we acquired images during a phase in the cardiac cycle where the coronaries were actually moving. So this is actually during the 450 milliseconds. So imagine if you have 1,000 milliseconds RR interval for someone who has a heart rate of 60, the 450 milliseconds and above might fall close to the P wave if patient's heart rate is fast. And this is exactly the reconstruction of this right coronary artery is not interpretable because of the motion that we see over here around the time of the atrial kick. If you reconstruct at a different phase of the cardiac cycle, here we use the 350 milliseconds, or right over the T wave, which is the isovolemic relaxation time. This is the same patient. Look how now this coronary artery segment is interpretable and is motion free, and you can accurately assess for plaque burden and stenosis. This is another curved planar reformat showing you basically motion artifact on this right coronary artery. where you could see actually there is a discontinuation of this proximal right from the mid, and this is basically how coronary motion artifact appears on CT. Now let's move on to cardiac motion artifact. What I'm showing you here on these axial images, notice how you have a double shadow in the atrial wall. You had a double shadow here in the posterior left atrial wall. So just for anatomical orientation, this is the aorta, this is the pulmonary artery, this is the appendage, this is the left atrium, the mitral valve, and the left ventricle. And when your temporal resolution is not enough to freeze the cardiac motion, this is exactly what you're going to see. So notice about this speed, how the lower the temporal resolution, you're actually more prone to have artifacts versus if you have actually a much better temporal resolution, you actually are not prone to have such artifacts. So this is from the same patient. Notice how you have this double edges on the aorta, double edges on the atrium, double edges on the posterior left atrial wall. And the reason why we do see this cardiac motion artifact, because when we acquired images on this patient's EKG, I hope you all agree with me that there are very nice flutter waves and a very irregular RR interval. So we actually acquired images during systole, which is why basically we see all this motion artifact on the CT. Now remember when we said that when we acquire images of the cardiac cycle, it's done over multiple cardiac beats, and at the end you actually have to stitch all these slabs together. So sometimes you can actually run into what we call a misregistration or a step artifact. I don't know if you appreciate here the proximal right coronary artery. If you take a look at this arrow, how it actually moves out of phase, and it actually almost appears that there is a double coronary artery. And that basically happens when we try to reconstruct those images and put those slabs together. We actually have had a misregistration artifact. If you appreciate it right over here, you see there are two coronary arteries running on the RCA course. This is exactly how it looks like, the proximal right, and then the slab immediately after it. It's completely out of phase because of it was not registered correctly, and this is how it looks on the 3D volume rendered image. Now, how can we alleviate this misregistration artifact? In our Siemens dual source scanner, which is specific for it, you have this high pitch scanning mode. What does this mean? This means that I can actually have the entire field of view, which is the heart, imaged with a single beat, notice here with a single heartbeat, and the table moving fast, by which I have all the data acquired with a single cardiac cycle. So there is no longer a step and shoot because the beam or the CT beam is on all the time, but it's only triggering during this period of the cardiac cycle here. Notice how it's triggering immediately after the T wave and really kind of in diastole where you want to acquire those images right over here. And our temporal resolution in the CT scanner is around 66 milliseconds. And notice how basically I can acquire this data within this time interval, and I can have actually a motion-free image. This is basically a patient who you can achieve a sub-millisievert radiation dose. This is a reconstruction of the LAD in multiple views. And notice how actually these images look motionless. So there is no artifact, neither from a step artifact. And also because the patient's heart rate was slow, in this case was in the 60, we were able to kind of acquire images with very low radiation and with a single beat acquisition. So this is basically another case where you see those multiple step ladder artifacts. Again, it's because of the misregistration, where this slab, when I want to try to combine it with the other slab, I actually have created multiple lines of artifact. And really the solution for it is basically people can use, as we said, the high pitch spiral scanning mode, but also there are scanners in the market like the GE and the Toshiba that have wide coverage detectors. So they call them volumetric scanners. With wide access on the Z coverage, I can acquire the entire field of view, which is the heart, with a single heartbeat acquisition. Breathing motion artifact, and for our CT fellows, this is a board question and it's a low-hanging fruit. Really, if someone did take a breath during the scanning, take a look at the sternum. This is the sternum over here. This is the posterior lumbar thoracic spine. And notice how there is a break in the line of this sternum bony window. And if you take a look at the slab of the right coronary artery around the same segment, you see actually this motion. This is not because of coronary motion. This is because of respiratory motion where the patient took a breath in during the scanning acquisition. Always for our techs, you want to practice breath holding with the patient, and a single beat acquisition or a high pitch scanning mode is probably going to be the one that gives you the fastest and the minimal amount of breath hold in order to acquire all the data. Now, when we talk about streak artifacts, so these are basically, remember that the X-ray beams have to penetrate through the patient's body and hit the detectors. So what happens is that there are high energy and low energy X-rays. When the low energy X-rays become attenuated, then you're going to have an X-ray beam that has been hardened. And when that actually happens with a higher weighted average, then actually everything that has metal, anything that has calcium, and anything that has high contrast is actually going to create what we call a streak artifact, or some people call it a beam hardening artifact. Let's take a look at an image, as an image is worth 1,000 words. So this is a stent in the left anterior descending artery. And notice how there is actually an artifact in the middle of the stent I'm not able to visualize well. And the reason behind that, because actually this metal has created a lot of attenuation of X-ray beams, so it actually obscured the area of interest, which is the stent. How can we resolve around this issue? We use a different filter, a post-processing reconstruction filter, which is a sharp filter. Notice how this edge of the stent actually becomes well-defined. The center of the stent and the contrast is actually not blooming, and you no longer have any artifact. So this renders the image quality better, and at the same time of a good diagnostic accuracy. This is a patient with a mechanical mitral valve. Do you see those artifacts that are black shadows here and here? This is exactly what we see, those streak artifacts. Anytime you have metal, you could also see that. This is a pacemaker lead in the right atrium. This is a coronary sinus lead in the LV, and you could actually see it on the non-contrast along with the contrast-enhanced images related to metal. In CT, the Achilles heel of CT imaging is calcium, because calcium will actually create a lot of blooming, and the higher the calcium burden, you're not able to see inside the vessel. So this is here is a reconstruction of the LAD. And notice how you have this basically dense calcium that's actually affecting the assessment of the lumen, because what happens with calcium, you have this phenomenon called partial volume averaging. What happens is that tissues that have different properties, and they are in the same imaged voxel. Voxel is a pixel in 3D in an X and Y and a Z plane, and the weighted average of these pixels, they become attenuated within that voxel. And we do know basically that calcium has a very high Hounsfield in it. It actually creates a lot of attenuation of beams. So notice that the calcium, instead of occupying a small pixel, it actually takes over and averages out the adjacent pixels, which is why it actually makes the assessment of the lumen different, because there are different densities within that area. So the weighted average is going to be high, hence you're going to create multiple areas of calcium that's going to take over the lumen of the coronary artery. The noise in CT usually occurs when you have what we call photopenia, or low photon counts, typically seen in obese with the higher BMI, and everything is big, unfortunately, here in Texas. So what are some of the solutions? You can either increase the tube voltage, but remember that this can exponentially increase the radiation dose. Very rarely we go above 140 kilo electron volt. The usually, or the standard tube voltage is the 120. You can also increase the slice thickness, which basically will improve your signal to noise ratio, or you could use basically soft reconstruction filters. So if you appreciate this image over here, where there is a lot of noise, there's almost like kind of a sandpaper appearance. And notice how on this image here, once I actually thickened the slice and used the soft filter, this image has a better signal to noise ratio. So less noise, better signal, and it's a win-win situation. The same thing here on this slab, where I've increased the slice thickness from 0.5 to 1. Now I have a better image signal to noise ratio. This is with regards to CT for the first half of the talk, and then we're going to move on to MRI imaging artifacts. Now the main categories for MRI imaging artifacts are basically, again, motion, if the patient moved or if the patient took a breath during the examination. Remember, when we do MRIs of the heart is moving all the time, so you have to actually at least have the patient hold their breath when you do those acquisitions. Gating artifact can occur, flow artifact can occur, hardware, physics related to metal and shift. But really kind of the best resources, and I know our CMR fellows, most of them are on PTO, but these are kind of the great resources to kind of dive in the common artifacts, how to recognize, but even more importantly, how to avoid. So this is something we see not infrequently if you have someone who's claustrophobic, someone who's not able to hold his breath. You see how this image looks fuzzy at the cardiac field of view. This is the LV, this is the RV. Look at the abdominal structures, they're also kind of fuzzy. And the reason behind that, because the patient did not hold his breath. Notice how the diaphragm actually is moving. So this is a very common scenario where patients are not holding their breath during CMR, and that can jeopardize my image quality. Some of the solutions in order to minimize breathing artifact is I actually can shorten the acquisition time by reducing the sampling case space lines. And sometimes you can actually add more lines every time you're acquiring data. You can actually add more lines per volumes per second. And the last but not least is similar to echo, where you can go to real-time imaging acquisition rather than retrospective or segmented acquisition. Now, gating artifact, we know that CMR data is acquired what we call in a segmented fashion. What does this mean? Meaning that the data is not acquired over a single cardiac cycle, but it's acquired over multiple cardiac cycles. And the most common mode of gating is retrospective gating in the absence of irregular heart rhythm or arrhythmias. So this basically should show it to you nicely here. You have an R wave and an R wave. And notice how we create bins between the RR interval. And with every phase, we actually start sampling lines of data. So this is what we call the case space lines. And with every quote unquote acquisition, we create volumes. And with retrospective gating, what you're doing basically is that you're sampling the data across the entire cardiac cycle from 0 to 100%, and then basically filling in lines of data with every phase until you're actually able to acquire the whole images of your cardiac field of view. So retrospective has basically all the data between the RR interval versus prospective, where I actually tell the scanner that recognize the R wave and then start acquiring images a few hundred milliseconds after the R wave. And normally the scanner will stop before the second R wave, and then it basically goes back and starts sampling again. So we're going to see the advantages of one over the other. When someone basically is having AFib with RVR or is having a lot of PVCs, so anytime you have a heart rhythm abnormality, it's going to affect the entire image acquisition. So this is quote unquote is a 5-chamber view where you can see the aorta, the RV, the LV, and the LA. But I hope you agree with me that this image is really kind of suboptimal because there is a lot of artifact. And notice how this is basically arrhythmia artifact, which is affecting the quality of your image. You're not seeing the borders well. What happened was this patient did have atrial fibrillation. So when I use the retrospective gating, because the RR interval is variable, and every time you're filling lines of data in one RR interval is not the same as the other RR interval, you actually have this blurriness in the endocardial border definition, versus if you actually use what we call a prospective, since the diastolic filling period is variable in AFib, but your systolic filling period is the same, or ejection period, then typically when you omit the diastolic image and you only acquire basically images prospectively during the period of the RR interval, then you actually have a much better signal to noise ratio. Hope you agree with me here that the blood myocardium interface have a much better resolution and edge definition than here. The blood myocardium interface is very blurry and it's very actually noisy. Now when we talk about phase wrap, or the other basically term of it is called aliasing artifact, and this is inside the scanner when part of the patient's body lies outside the field of view and it's being wrapped to the opposite image. So this basically meaning that the field of view is smaller than the spatial extent of your radiofrequency excitation pulses that Dr. Shah was talking about. And some of the solutions for it is simply just increase your field of view. So if you notice this RV inflow, outflow, so this is the tricuspid valve, this is the pulmonic valve, this is the liver. Notice how part of this patient's arm is actually wrapping over the right ventricle. So you can see actually there is this artifact from the arm. And one of the solutions basically to get rid of that is, as Dr. Shah has mentioned, that there are ways that you can encode in the phase direction when you want to sample your images. So for example, here there is a lot of artifact from this patient's arm. So instead of basically going from a right to left phase encoding direction, it's much shorter to do it from an anterior to posterior. And now all this wrap or phase oversampling has completely gone away. And now you have a much better image quality. We could also see this wrap artifact during late gadolinium enhancement. So take a look at this artifact from out to in. You have all this white band, and the question is this white band affecting the apical septum, is this scar or is this artifact? And this clearly looks like an artifact that's causing a false positive, high signal intensity and gadolinium enhancement. So you're really kind of going to be cognizant about that during patients' acquisitions. The power horse of cardiac cine imaging is the steady state free precession. So basically with that, what happens is that there are series of pulses that normally we actually administer in order to kind of get the tissues to the transverse plane and then start sampling. So if I actually have a lot of dephasing of those spins, especially with a higher magnetic field, remember the commercially available scanners for cardiac imaging are 3 Tesla or 1.5 Tesla. With a larger magnetic field, there's a lot of perturbation of the protons that when they spin, a lot of them are going to be out of phase, and that's why it actually creates a lot of field inhomogeneity. If we actually use a special type of coil called shimming, meaning that I want to focus my region of interest of the heart alone, and I also lower my temporal resolution instead of increasing my temporal resolution, that can also get rid of some of the artifacts. So I hope you agree with me here in the mesenteric or in the abdominal viscera. Do you see all these banding artifacts? We commonly see that. You see also another banding artifact here. So thankfully, they're not affecting my cardiac field of view because they're away from the heart, and they're usually seen in stationary tissue. And that's basically because of the magnetic field inhomogeneity. The further out you are from the center of the magnet. This is a patient, let me see if this one plays. So this is a patient, if you appreciate, has a bicuspid aortic valve. He has a commissural fusion between the right cusp and the left cusp. But notice how the center of this valve is actually susceptible with a lot of flow artifact. If you guys appreciate, but there is basically this, a lot of high signal and low signal intensity. Every time the valve opens, you got this, some people call it pulsatile flow artifact. And one of the ways that actually we get rid of it, instead of using the power horse of steady state free precession, we can actually switch to something called the gradient echo. So it basically has a lower resolution, but notice how actually now the signal to noise ratio is much better. And I've actually nicely can see now the opening of the valve. I can nicely see the commissural fusion, and I no longer have that quote unquote pulsation artifact. Sometimes you could even see flow-related artifacts. So this is the left atrium here. This is the aortic valve. You can see there is blood flow coming in from the pulmonary veins, and these actually do create the signal loss. Signal loss is when you start seeing black area. So that's not because there are stenosis in the pulmonary veins, but that's basically the flow across the veins. In a steady state free precession sequence, you can commonly see that, and this is all related to blood flow. Similar to how we saw the blood flow in the bicuspid valve, creating the same artifact, we can get the same thing over here through the pulmonary veins. We did talk that the higher the magnetic field, or the stronger the magnetic field, the more you're going to get artifacts, especially when it comes to the magnetic field not being homogeneous. So these are basically, if you appreciate with me over here, these are the shading artifacts over here. You can see there is a little bit of a perturbation of the signal over here. There's also some signal over here and a lot of bands in this patient. Similar also seen in stationary tissue. So a lot of the time it's not going to affect the heart because thankfully there's not a whole lot of fat around the heart, but you can commonly see it in the stationary tissue, usually in fat tissue. In people who come for the stress imaging lab, you really do not want to overcall stress perfusion abnormal because there is also this phenomenon called the dark rim or the Gibbs artifact. So what happens after the contrast load comes into the LV, you have this 1 pixel intensity low quote unquote perfusion or hypodense area where you can see actually this area here looks a little bit black. And then after that, with cardiac cycles, it actually starts to get better and it starts to pick up contrast. So one of the explanation from an anatomical standpoint is that sometimes you can have what we call a volume averaging. So especially the area where you have a high contrast load and then there is no contrast in the myocardium, that actually area where you have more of the high contrast area will actually take over some adjacent areas. So it's going to appear as if the area is black. Sometimes it can also occur from what we call susceptibility artifact, which is another quote-unquote magnetic field artifact. But notice how in this patient, when you're doing the stress imaging protocol, this area here that looks kind of low density goes away after 3 cardiac cycles. But take a look at this area here in the inferolateral wall. So how do you differentiate a true perfusion defect related to CAD from artifact? Is that CAD perfusion defect does not go away, as you can see it over here, versus the dark rim artifact usually goes away with few cardiac cycles because the gadolinium has washed out and no longer you have this contrast load coming in. So hopefully this was kind of a good case to show you what an artifact would look like, but what a true perfusion defect looks like here. This area is not picking up gadolinium, and it's truly suggestive of a flow-limiting stenosis. In patients who have ion overload, so ion basically can create a lot of magnetic field inhomogeneity from the ion metals. So what you typically see, this is a patient who has liver ion overload. Notice how the entire field of view on this sagittal image is creating a lot of what we call off resonance. So you can see here the images are so blurry and motiony that it really can affect your cardiac field of view. And also people who do get IV ion treatment, normally we wait before we send them for a cardiac MRI because they're going to have a lot of magnetic field inhomogeneity. You're not going to be able to accurately assess their cardiac function, see the walls well. So for people who got treated with ion, you need to wait at least 30 to 60 days before you can consider them for a cardiac MRI because of the off-resonance artifact. This is a patient who has sternotomy wires, and again, we rely on hydrogen atoms to acquire our CMR images, as Dr. Shah showed, but basically metal has no hydrogen in it, and that's why basically it creates this quote-unquote susceptibility artifact, or some people call it a signal loss artifact. This is actually a patient here who has a pacemaker generator. And notice that when we are sending radiofrequency pulses in order to excite the protons and acquire images, notice how all this outside the heart artifact that you are seeing, this signal loss is all because of the pacemaker generator, which has a ferromagnetic material, is actually creating a lot of perturbation. The field is not homogeneous, and that's why you actually have a lot of signal loss that you see it. But thankfully in this patient is not affecting my image quality because I can nicely see the border of the myocardium. And as we said, the steady state free precession has a lot of pacemaker artifact, which is why our techs always use the gradient echo. It's just a different engine sequence that they know to use. Why? Because you have less artifact from a pacemaker generator. So this is actually a nice case of radiofrequency artifact related to a pacemaker generator. There are basically also what we call in late gadolinium enhancement imaging. So after injection of contrast, 10 minutes, we acquire what we call the delayed enhancement imaging. And sometimes basically you can have arrhythmia artifacts, what we call ghosting artifacts. So these, you see those lines here over here across this sagittal image? You see this big line over here? These are basically artifacts. And if they're happening and they're because of ECG gating, so that's basically because of patient throwing a PVC or the patient's heart rate is fast, then usually it's going to affect the cavity alone. But if the patient is not able to hold their breath, then usually you're going to see this ghosting artifact from the adipose tissue all the way over the heart. So this is a ghosting artifact because the ECG gating issue. This is here is a ghosting artifact. Why? Because it's starting from the stationary tissue across the heart because the patient did not hold their breath. So we have two types of images in cardiac MRI. We have the free breathing and we have the breath holding. Always the breath holding is going to give you a much better resolution, a much better signal to noise ratio, but the free breathing you're going to jeopardize resolution and signal to noise ratio, which is why it's really critical that patients sent for the MRI scanner, they basically know that this is not a brain MRI where you can go down and sleep. You have to be awake because you're going to be subjected to a lot of breath holding. The second thing basically is what we also see with late gadolinium enhancement is basically the arrhythmia artifact. So this is basically a patient who has on his LGE, again, do you see those fine lines of data? So the question is, does this patient has a scar in this area? It looks a little bit less black, and I'm really not sure whether this is true scar or not. But notice that if this patient, when you are acquiring the data, and let's say this patient has an irregular heartbeat, which he does, and if you're acquiring the data every heart cycle, you're not actually allowing enough time for the protons to fully relax, and instead you actually trigger in every other heartbeat. Now how you notice how you actually have a much better signal to noise ratio, much better resolution, and you can see there is no evidence of scar in this myocardium. So you notice all this area of ghosting, that's basically because of ECG gating artifact in this patient who had an irregular heart rate. For the sake of time, I'm not going to go to the LGE, and then I'm going to finalize with the what we call the chemical shift artifact. We commonly see it on CMR, And the reason behind that, because the hydrogen protons in water and fat, they precess or they spin at different frequencies. Usually there's a difference of 3.5 particles per million. And what happens is that they're in the frequency encoding direction, you'll have a misregistration in those pixels. Meaning that in the same slice, you can have fat and water, but because they have different frequencies, they cancel each other. So the signal that you get is gonna basically be black. So this is exactly what we are seeing over here. This is a patient on a scar imaging, and this is a patient who has a pericardial effusion. So the interface between water and fat is gonna appear black, not because the patient has a thickened pericardium, but that's just an inherent limitation of the SSFP sequence. This patient here, between the pericardial fluid along with the epicardial fat, also has this quote-unquote black artifact. So we call it basically chemical shift, and this is something that's specific for MRI physics. In an area between fat and water, you can actually see this mode of artifact. So to conclude, the knowledge about the appearances of artifact is essential to avoid misinterpretation, and after scan and altering the scan preparation and the scanning parameters accordingly will be the way in order to kind of get away from those artifacts. With that, I would like to conclude and thank you all for your attention. Happy to take any questions from the audience.
Big question. The management of these artifacts, are they currently in your lab, are they mostly in the hands of the technicians that are smart enough to think about make corrections, or is it you guys there?
Is this on the CT or the MRI? MRI. Yes, this is something that our techs, MRI techs, they recognize, because we as physicians, we're not sitting at the scanner. So every time they acquire an image, they actually see the raw data and they see what the image looks like. And a lot of the times, the most common reason why people have artifacts on MRI is that they're not able to hold their breath for 5 or 7 seconds. So on the fly, they actually know how to change some of the protocols and change some of the sequence parameters in order to shorten the acquisition time. But also they are trained in looking at ECGs, trying to get away from arrhythmia artifacts. So this is something on the MRI, the techs have the first-hand exposure than the MRI attending. All right, well, I guess we finished 20 minutes earlier. Have a productive RVU day, and until next week, you guys take care.